Good morning, everyone. At the outset, thank you for the organizing committee for giving us this opportunity to participate in the workshop. We invite Dr. Nigar Fathima, who is a consultant histopathologist at Apollo Health City, Hyderabad, to take us through tubulointerstitial and vascular disease pathology. Dr. Fathima.
So, good morning, everybody. After an exhaustive session on the glomerular diseases, we will proceed to the tubulointerstitial and vascular diseases now. In a kidney biopsy, the glomerulus always tends to steal the limelight, and now for the next 30 minutes, we will shift our focus to the tubulointerstitial compartment, which is equally important and adds value to the report. So, this is a structure of normal tubules and the interstitium. The black arrow depicts one second. The black arrow depicts the proximal convoluted tubule, where you can see abundant eosinophilic pink cytoplasm, and the red arrow denotes a distal tubule where the cytoplasm is scantier and paler. On a PAS stain, you can see the fuzzy magenta colored brush border, which is highlighted by the black arrow, and you can see that the tubules are very closely opposed. They are back to back in arrangement and with only little interstitium in between. Coming to the tubules, we first look at the architecture if there is any injury or atrophy, then the epithelium to look for injury, inflammatory cells, infections, presence of any crystals or pigment, and in the lumen we look for the casts. This is how the morphology of injury looks like. There is irregular luminal dilatation. There is loss of some nuclei over here. There is flattening and denudation of the epithelium. There are some missing nuclei over here. And in the third picture, you can see that some tubules show loss of brush borders. The tubular epithelial cells show cytoplasmic vacuolations. The epithelial cells undergo apoptosis and are sloughed off into the lumen as this pink cell acellular debris, and these pycnotic nuclei represent the apoptotic cells. As a part of regeneration, the tubular epithelial cells extend beyond their normal confines into the Bowman's capsule. This is called tubularization of Bowman's capsule. Next comes atrophy. Atrophy is a feature of chronicity, and it is graded as mild, moderate and severe based on the number of atrophic tubules, percentage of the atrophic tubules in the cortex sample. Atrophy can be of classic, endocrine or thyroidization type. The classic type is best appreciated on PAS and silver stain. You can see that the atrophic tubules have a diminished tubular diameter. There is irregular wrinkling and thickening of the basement membranes. The same is appreciable on the silver stain also. The next is the thyroidization type, where there are distended tubular segments containing eosinophilic proteinaceous material with a thinned out epithelial lining. These are PAS positive, and this morphology resembles that of thyroid follicles, and hence the name. The next is endocrine type of atrophy, where there are small tubules with no thickening of basement membranes and the lumen appears to be lost, and these are back-to-back placed, giving the appearance of an endocrine organ. These are mostly seen in prolonged ischemia and hypertension. The tubules can show certain calcium containing crystals like phosphates and oxalates. Phosphate crystals on H&E, they are basophilic and have a bluish purple appearance, and on von Kosa stain they take up a black color. The third image shows oxalate crystals which are translucent and they are strongly birefringent under the polarized light. Coming to interstitium, the normal cortex shows very minimal interstitium, while in the medulla it's slightly more expanded. We look for edema, fibrosis, inflammation or the presence of any deposits. This image shows edema, where there are tubules are widely spaced and there is increased interstitial space with a watery loose substance, which is edema, in contrast to fibrosis, where there is collagen deposition, which is highlighted as blue color on Mason trichome stain. The type of inflammatory infiltrate in the interstitium usually gives a clue to the etiology. When there are prominent neutrophils and accompanied by neutrophil casts, it's probably an infective etiology. A prominence of eosinophils in the interstitium suggests a drug or hypersensitivity reaction. And aggregates of lymphocytes accompanied by IFTA is seen in chronic interstitial nephritis. Plasma cell prominence in the infiltrate and plasma cell tubulitis is a clue to polyomavirus nephropathy, and in this case you can see a slightly enlarged nucleus which could be a polyoma infected cell. The next is granuloma. There are interstitial aggregates of epithelioid histiocytes with occasional multinucleated giant cells. These can be seen in tuberculosis, sarcoidosis or drug reactions. When the interstitium is expanded by sheets of these monomorphic atypical lymphoid cells, a lymphoproliferative disorder needs to be suspected. Coming to interstitial deposits, when there is an outlet obstruction, the tubules undergo rupture and the TAM phosphoprotein is extravasated into the interstitium, which elicits an inflammatory response around it. And next comes these PAS negative deposits in the interstitium, which is amyloid. This was about the introduction to tubules and interstitium. The tubulointerstitial diseases can be grouped into these various categories. Due to time constraint, we will limit our discussion only to some of the entities in each category. The first is genetic. It includes nephronophthisis, ADTKD, genetic crystal deposition disease, and karyomegalic interstitial nephritis. In nephronophthisis, this is an autosomal recessive group of disorder which is due to mutations in genes encoding for the primary cilium. What we see in the biopsy is glomerular sclerosis and tubular atrophy accompanied by fibrosis. There are pools of extravasated TAM phosphoprotein. Sometimes there can be glomerular cysts and tubular basement membrane duplication. This is one of our cases where we could demonstrate floret shaped tubules in which we can see that there is branching of tubules in more than 4 directions, and this image shows macula densa like condensed nuclear appearance of the proximal convoluted tubule. Among the genetic crystal deposition disease, the first is urate nephropathy. Urate crystals are dissolved during routine processing, and all we see on the biopsy is interstitial granuloma surrounding an empty space. Next is cystinosis, which is again due to the genetic defect, an autosomal recessive lysosomal storage defect. Cystine crystals are again dissolved during routine processing, and what we see on a biopsy are usually these multinucleated podocytes or multinucleated tubular epithelial cells. The next is 2,8-dihydroxyadenine-urea. It's due to the deficiency of the enzyme APRT. What we see on biopsy is these muddy brown to greenish fan-shaped crystals which are polarizing under the which are birefringent under polarized light. Next is karyomegalic interstitial nephritis. As the name suggests, you can see that the nuclei are significantly enlarged, and these changes are not limited just to the kidneys, but they can be seen in other organs as well. When these cells are shed in the urine, they can very well mimic a malignancy. The next category is infections. When there is a prominent neutrophilic infiltrate in the interstitium, with some of them infiltrating the tubular epithelium along with few neutrophilic cars, an acute pyelonephritis needs to be suspected. A urine culture study might be essential to identify the causative organism. Next is xanthogranulomatous pyelonephritis. It's a mass-forming lesion, and it can mimic a carcinoma on clinical examination on gross and microscopy. You can see that there are sheets of these macrophages with abundant vacuolar to clear cytoplasm, and these very well mimic a renal clear cell RCC. Malakoplakia is caused usually by E. coli. There is defective macrophage bactericidal function, and what we see is sheets of macrophages containing these characteristic cytoplasmic inclusions called Michaelis-Guttman bodies. These are PAS positive, and they contain calcium and iron, and hence they can stain for von Kosa and Pearl stain also. Whipple's disease, this is caused by Trophorima whipplei. This is very similar to that seen in the intestine. There are aggregates of these macrophages which are laden with PAS positive bacilli seen in the glomerular tufts or in the interstitium. Coming to viral infections, this is a post-transplant patient where we could see that many of the tubular epithelial cells are markedly enlarged, and on high power we can see that there are cytoplasmic basophilic inclusions and intranuclear inclusions also. similar to the owl's eye, hence the name owl's eye appearance. This was confirmed using IHC and it was positive for CMV. And polyoma virus infections, they show occasional enlarged nuclei which have a smudged or ground glass appearance accompanied by a plasma cells rich infiltrate in the interstitium. And this on IHC for SV40 will confirm it to be a polyoma virus nephropathy. Similar to viral infections, these fungal also are seen in immunocompromised patients. Mucormycosis, this image shows artery completely occluded by broad hyphae of mucor, and some of them are seen in the hilar vessels and in the capillary loops also. This is an image showing histoplasmosis. The broad arrows represent RBCs which are negative. They are the black dots here are the histoplasma organisms. They are much smaller than RBCs. These are two tubular lumina occluded by these yeast forms and occasional slender septate hyphae of Candida. This is a cryptococcus showing a halo around. These can be seen in the interstitium also, and they stain for mucicarmine stain and silver stain. Immunological diseases of the kidney can be due to exogenous agents, alloantigens or autoantigens, or sometimes unknown antigens. Coming to drug-related interstitial nephritis, there is a prominent eosinophilic infiltrate and sometimes there can be this granulomas. The second image shows an ill-defined histiocytic aggregate forming an ill-defined granuloma. Anti-TBM disease shows autoantibodies against the TBM. On light microscopy, they show interstitial inflammation, IFTA, and injury, and the infiltrate can sometimes show these multinucleated giant cells adherent to the TBMs. The typical IF shows linear staining along the TBMs for IgG and C3c. IgG4-TIN is a mass-forming lesion again, and this is a nephrectomy specimen where we can see that the inflammation is concentrated mostly around the periphery, and towards the center of the lesion there is a more dense fibrosis. We can see that there are certain lymphoid follicle formation also. The infiltrate is mostly composed of plasma cells and some eosinophils, but granulomas are never seen. There is interstitial fibrosis in a storiform pattern, meaning they radiate in multiple directions like the spokes of a wheel. On immunofluorescence, there is IgG staining along the TBM and interstitium. This can be confirmed by IgG4 IHC, which stains the IgG4 positive plasma cells. The next is anti-brush border disease. This is due to antibodies against LRP2, which is lipoprotein receptor related protein 2, and there is a characteristic IF finding of this. There are deposits along the TBM, and towards the luminal side along the brush border also there is staining. We can see that there are two layers of green over here, and there is segmental staining along the basement membrane and segmentally along the capillary loops also. This is a textbook image of paraffin IF of LRP staining the brush borders. On indirect IF, when the patient's serum is incubated on a normal kidney, it stains positive, meaning that the patient's serum has autoantibodies to brush borders. So these are some of the toxic related entities. This was a patient with renal dysfunction showing cytoplasmic brownish pigment in the tubular epithelial cells, which was confirmed as hemosiderin on pearl stain. On further evaluation, this patient was found to have paroxysmal nocturnal hemoglobinuria. And this was a patient of March hemoglobinuria showing these reddish brown granular casts, which was confirmed as hemoglobin on IHC. In rhabdomyolysis of any cause, like strenuous exercise, prolonged statin usage, or snake bites, etc., can show this brownish discoloration of pigments, which can be confirmed using myoglobin IHC as myoglobin casts. In patients with liver failure, there can be this brownish golden cast in the tubules, which can also be seen in the urine sediment, and it can be confirmed using Hall stain. Next comes CNI toxicity. In acute phases of cyclosporin toxicity, there will be tubular injury, and there is fine isometric vacuolization in the proximal tubular epithelial cells. And in the later chronic phases, there is striped fibrosis. There are these broad blue bands with intervening normal tubules. And peripheral nodular hyalinization of the arterioles is seen. You can see that there are these pearl-like beaded appearance along the periphery while the luminal side is spared. Ethylene glycol is an industrial compound which on oral ingestion causes toxicity. It's a suicidal agent. There is coarse cytoplasmic vacuolation in the proximal tubular epithelial cells, and there are occasional oxalate crystals within the cytoplasm which are highlighted under the polarizer. Balkan endemic nephropathy and Chinese herb nephropathy are related entities, and they are due to aristocolic acid toxicity, and they show zonal distribution where there is increasing severity of IFTA and global glomerular sclerosis from the juxtamedullary cortex to the outer cortex. You can see that close to the medulla there is related sparring. Next, metabolic conditions: nephrocalcinosis, phosphate nephropathy, urate and bile gas, which we have already seen. Renal ischemia can cause acute tubular injury or renal cortical necrosis. This image shows an interlobular artery branching into the afferent artery into the glomerulus. There is a fibrin thrombus occluding this vessel, and you can see that there is marked glomerular congestion and interstitial hemorrhage. And towards the bottom right, there are some viable tubules, while most of the others show only pale pink ghost outlines without nuclei. Obstructive causes like benign prostatic hypertrophy, tumors, calculi, gravid uterus, and radiation therapy can also cause interstitial nephritis. The neoplastic diseases include monoclonal immunoglobulin tubulointerstitial diseases. The first among them is light chain cast nephropathy, where the tubules show this needle-shaped or hyaline or fractured casts, which are usually surrounded by a histiocytic reaction, and these casts are negative on PAS stain, and on empty they are usually fusionophilic, or sometimes they can be polychromatic, meaning there's a mix of red and blue. And this image shows a fracture. There is a light chain restriction on IF, meaning it stains only for one of the light chains. Next is light chain Fanconi syndrome, where the proximal tubular cytoplasm shows these needle-shaped crystals, which again show light chain restriction. And on EM, they show this needle-shaped structure with these vertical striations. Next is amyloid cast nephropathy. There are these tubules which are distended with these casts. These are PAS negative, and on silver stain, they show these peripheral spiculations. And on Congo red, they are congophilic and show apple green birefringence. Coming to the next compartment, the blood vessels. This is a normal structure of an artery, where you can see that there is a wavy pink line which is refractile, and it's called internal elastic lamina. The inconspicuous space between the endothelium and the elastic lamina is the intima, and beyond it is the medial layer. This is a smaller interlobular artery which is branching into the afferent arterioles. This is a glomerulus showing afferent and efferent. The afferent enters the glomerulus at almost nearly right angles, while the efferent curves around the Bowman's capsule. Coming to TMA. TMA is a pattern of injury and not a specific diagnosis. Again, you can see that there are luminal thrombi in these vessels and few thrombi in the capillaries also. This is a high power showing this granular characteristic of the fibrin, and there is some karyorectic debris here. This is best appreciated on empty stain, and these stain as red, which are fusionophilic. And there is intimal mucoid edema over here causing luminal occlusion, and there is concentric lamellation of the medial layer similar to the cut surface of onion, and hence it's called onion skinning appearance. This image shows few fragmented RBCs and little bit of fibrin over here. The arteries here can show a bluish, slightly bluish discoloration of the intima, which is intimal mucoid edema. And in chronic phases, there is duplication of basement membranes and mesangiolysis. The changes in hypertension include intimal fibrosis. We can see that this pink wavy line denotes the internal elastic lamina, and then there is collagen deposition in the intima. And the last image shows this red thickened layer is the medial hypertrophy. In diabetes, in addition to intimal fibrosis, it is known that both afferent and efferent arterioles will show this hyalinosis. Next comes renal vein thrombosis. Few cases of nephrotic syndrome can show renal vein thrombosis. This is a venule which is showing a small thrombus adherent to the endothelial layer. And in the glomerulus, we can see capillary congestion, and there will be neutrophilic infiltrate in the glomerulus and also in the PTCs. Renal artery thrombosis, it can be seen in hypercoagulable states or after following a rupture of atherosclerotic plaque. This is a bifurcation of an artery which is completely occluded by a thrombus. You can see alternating layers of RBCs and fibrin. And in the interstitium, there is prominent hemorrhage, while towards the bottom right, that's all necrosis. Atheroembolic renal disease is most commonly seen following an invasive procedure like angiography or plasty or bypass surgery, etc. And what we see are these empty spaces which are cholesterol cliffs because the cholesterol dissolves during processing. This is a case of granulomatous vasculitis where you can see that the arterial wall is completely disrupted by these aggregates of histiocytes, and there's a small interstitial ill-defined granuloma here. On the silver stain, you can appreciate that there is a disruption of the intimal layer, elastic lamina, and the entire wall by this granuloma. And ANCA vasculitis is a possible etiology in this case. So to summarize our findings, interstitial neutrophils with neutrophil casts suggest acute pyelonephritis. Polymorphonuclear cells in PTCs can be seen in renal vein thrombosis or acute antibody-mediated rejection. Medullary angiitis with neutrophils is usually seen in ANCA-associated vasculitis or drug hypersensitivity reaction. Interstitial lymphocytes with edema and tubulitis are usually seen in acute interstitial nephritis. Interstitial lymphocytes with prominent interstitial fibrosis is seen in chronic interstitial nephritis. And sheets of monomorphic atypical lymphoid cells with or without infiltration into the surrounding fat suggests a lymphoproliferative disorder. Eosinophils point towards a hypersensitivity reaction, acute interstitial nephritis, or they can be seen in a diabetic nephropathy also. Coming to granulomas, non-necrotizing granulomas are seen in hypersensitivity reactions. Discrete granulomas are possibly due to sarcoidosis, and necrotizing granulomas are commonly seen in infectious etiology. Interstitial inflammation with positive IF findings. When there is linear staining of IgG, an anti-GBM disease is possibility. When there are granular deposits, it could be due to lupus nephritis, polyomavirus nephropathy, or IgG4 related disease. Coming to CAS, pigmented CAS like bilirubin are seen in acute liver failure, and these stain for Howell stain. Myoglobin stains are seen in CAS are seen in rhabdomyolysis, and they could be confirmed by antimyoglobin IHC. Tubules with iron pigment can be seen in hemolysis, and they can be confirmed with Prussian blue stain or in hemoglobin IHC. The other casts include Tam-Hosphol protein and light chain casts. Among the crystals, the polarizable ones are calcium oxalate and 2,8-DHA. Calcium oxalate are translucent, and while 2,8-DHA have a muddy brown color. The non-polarizable crystals include calcium phosphates, indinavir, and urates. And finally, about IFTA, when there is a diffuse pattern of IFTA, it's usually non-specific. A striped pattern of IFTA suggests a cyclosporin toxicity. A patchy or geographic with a jigsaw puzzle-like pattern and thyroidization suggests a chronic pyelonephritis. And when there is an endocrine change of the tubules, it's probably due to prolonged ischemia or hypertension. So a systematic approach with careful examination of each compartment aided by histochemical stains, IF and EM wherever necessary will aid in the diagnosis. Thank you for your attention.